Vanakkam. The AV fistula is a lifeline for a patient with a chronic kidney disease, and it is our aim to make it perfect so that it matures completely and is useful as a line for hemodialysis for the patient. Though the technique of this surgical procedure is very important in ensuring the success, more important is understanding the hemodynamics behind this fistula, because after all, we are making an abnormal connection between a vein and an artery, so there is going to be a disturbance in the blood flow. Will this blood flow cause any problems? Will it cause stenosis of the fistula ultimately? We shall see all that in this video. Rivers can have different types of flow. This is the Ganges or the river Ganga at the place called Rishikesh. Serene, smooth and very dignified. But just a few kilometers upstream in the same river, in places like Kaudiyala or Shivpuri, it is like this. Turbulent flow with rapids where you can experience rapid rafting. So these are the different types of flow in the same river at different places. The same is applicable to blood vessels also. When a patient has chronic kidney disease, the permanent solution would be a renal transplantation, which may not be possible for every single patient. The next best option may be a hemodialysis, and the commonest route of hemodialysis would be the distal vascular access in the form of the radio-cephalic fistula. The success of this AV fistula would mean life and death for the patient. So it is important that we understand this blood flow. How does this kind of flow occur? And especially when it is a distal AV fistula for vascular access and chronic kidney disease, what is it that ensures success? Our aim when we do an end-to-side anastomosis of the radial artery with the cephalic vein just proximal to the wrist, we are hoping for a blood flow like this. So what's going to prevent it? The hemodynamics of this blood flow. So we must understand the hemodynamics before we go ahead with performing an end-to-side distal AV fistula for vascular access. We want to achieve physiological maturity of the AV fistula. That literally means at the end of 6 weeks after performing the fistula, the flow rate should be at least 500 ml per minute or 600 ml per minute according to certain authors, and the minimal vein lumen diameter should be at least 5 millimeters. When we try to understand the normal hemodynamics of the radiocephalic AV fistula, blood flow in the cephalic vein is normally approximately 28 plus or minus 14 ml per minute only. But after it has been incorporated into the AV fistula and it is successful, it will have flow rates averaging between 600 to 1000 ml per minute. So how is the vein able to accommodate this much increase in volume and pressure? The answer lies in the adaptation that occurs in the AV fistula, that is mainly outward dilatation and wall thickening with less intimal thickening. This would result in a successful fistula. Let us try to understand this better. This is the normal structure of the vessel with the intima, media and the outermost adventitia. At the end of 3 weeks, a successful AV fistula will be patent and appear like this. Still no thickening would have occurred. Whereas at the end of 3 weeks, it is completely closed off and not patent at all due to thrombosis. It is called a primary failure of the AV fistula. At the end of 6 weeks, if the fistula is still working, it indicates good maturation, and the thickening will be mainly in the media and the increase in size would be outward dilatation. Whereas if the thickening is in the intima, resulting in narrowing of the lumen, it is called failure to mature. The normal adaptive process, that is, increase in thickness of the media, occurs to increase pressure, shear stress, and increased oxygen tension from the arterial inflow into the vein. In other words, the hemodynamics. The hemodynamics of the end-to-side AV fistula refers to the study of blood flow dynamics within the surgical connection where the end of one blood vessel, here the vein, is joined to the side of another vessel, here the artery. When this procedure is done, what happens and how can we modify it to get a good maturation that we have seen so far? When a vein has been connected to the artery in the end-to-side fashion like this, there is a change in the direction of the blood flow. And when this change occurs, there are two effects that are seen. The first is flow disruption. When blood enters the side of a vessel, it creates a flow disturbance at the junction, potentially leading to turbulence. The second effect would be what is known as the wall shear stress. This change in the direction of blood flow causes a stress on the vessel wall. So the first effect of flow disruption is turbulence. But to understand turbulence, we need to understand one more concept, that is laminar flow. And after understanding laminar flow, we need to understand the first effect of flow disruption, that is turbulence, and as a secondary effect, vibration. Normally, in an intact blood vessel, the rate of flow is least towards the edges. As it comes towards the center, it becomes much faster. This is known as laminar blood flow. This occurs so that the slow speed of blood on the periphery will not damage the endothelial lining. But when there is a change in the direction of blood flow, for instance, another vessel has been added and blood is flowing into this vessel from another direction, turbulence occurs. And when this turbulence occurs, it impacts the wall of the blood vessel like this. So the blood flow coming in from another direction will hit the wall at an angle which the wall or the endothelial lining is not used to. This is turbulence. As a response to this stimulus, endothelial cells react in two ways. They grow in size and number, and this growth occurs into the lumen. This schematic diagram shows the effect of endothelial growth into the lumen of the vessel following excessive turbulence. Our aim would be to reduce this turbulence that occurs. But turbulence is not the only problem. There occurs what is known as a vibration injury. When the blood flow coming at an angle hits the vessel wall vibrates. This vibration also causes problems. I'll give you an example of how vibration can be dangerous. Just look at this instruction on a bridge. All troops must break step when marching over this bridge. That is, when soldiers are marching over a bridge, they should not march with the same rhythm, because then their vibration and the vibration of the bridge may join together, and this force may be so great that it may break the bridge. The effect of vibration on the vessel wall is through the activation of platelets and leukocytes. This total effect is called vibratory disharmony. The accumulation of platelets and leukocytes at that point where the vibratory injury has occurred on the vessel wall will lead to congestion at that area and a high venous pressure building up. Along with turbulence, we had seen that the second effect of flow disruption is what is known as wall shear stress. Now that stress at the wall is proportional to the velocity gradient or the shear rate near the wall. This is represented by what is known as the Reynolds number. This Reynolds number is calculated by d into v into rho divided by nu, where d is the diameter of the vessel, v is the velocity of blood, rho is the density of blood, and nu is the viscosity of blood. If the Reynolds number is less than 2000, it usually has a laminar flow. But if it is more than 4000, the chances of turbulent flow are very high. And that turbulent flow, as we have seen, can cause intimal hyperplasia. This intimal hyperplasia results in what is known as a stenosis. This stenosis could be an arterial stenosis occurring at the junction of the artery and the anastomosed vein, venous return stenosis, that is stenosis occurring a little downstream in the vein that has been anastomosed end to side to the artery, or both arterial and venous stenosis. When an arterial stenosis occurs, usually due to surgical inadequacy, the amount of venous flow into the anastomosed vein becomes less, so the vein becomes flaccid with low pressure, leading to a collapsed vein, which is more prone for thrombosis. In a venous anastomosis, there is a buildup of pressure behind the stenosis in the vein, leading to a dilated vein. So far, we have seen the hemodynamics of the end to side anastomosis. But there is also a technique known as side to side anastomosis for radio-cephalic fistula. When two blood vessels are connected along their sides, creating a smooth, even flow of blood between them, it is often considered to produce more favorable hemodynamic patterns compared to an end to side anastomosis with less turbulence. Is it really so? Let us have a look. In 1984, Wedgwood et al. Demonstrated that the end-to-side technique is the method of choice for AV fistula. Their study showed equivalent patency rates with the two methods, but higher risk of hyperemia with side-to-side anastomosis. A meta-analysis of 16 studies including 6 randomized controlled trials comparing end-to-side technique, side-to-side anastomosis and side-to-side anastomosis with distal ligation of the vein. The conclusion was that the side-to-side anastomosis technique with distal vein ligation may result in significantly better patency rates as compared to the standard end-to-side technique. We have considered the hemodynamics of the blood flow that occurs within the AV fistula that we have created. But there is another problem that is going to occur when the procedure of hemodialysis actually begins, because there blood will be drawn out like this, sent through a pump and pushed back into the vein as shown. When this is done, there is going to be an altered hemodynamics again. When there is a low flow needle return, there is minimal turbulence and rapid return of laminar flow once the needle is removed. But if the needle return is going to be a high flow needle return, there may be a major turbulence leading to upstream stenosis from wall shear and wall aggregation. So the technique by which the hemodialysis is done can also alter the hemodynamics of the AV fistula and affect the maturity and longevity of the fistula. Though we have learnt a lot about the hemodynamics of the AV fistula, how is it going to help us? And is it possible for us to modify the hemodynamics so that we can get good results? Yes, there are 4 ways by which we can modify the hemodynamics. The first is vessel diameter matching, the suture technique, the angle of anastomosis of the vein and the artery, and the non-planarity of the anastomosis. The first is vessel diameter matching. Closely matching the diameters of the vessels involved, that is between the vein and the artery, is very crucial for optimal hemodynamics. This will ensure a smooth blood flow with minimal turbulence and pressure changes. If there are discrepancies in vessel size, there is increased shear stress, potential thrombosis, and compromised blood flow. But what size should I make the anastomosis? Can I make it very large? That is, make a large arteriotomy and make an angular cut in the vein so that I have a very large vein? In this case, what will happen is the amount of blood going into the vein is so large that the wall of the vein distal to the anastomosis gets injured, leading to stenosis and ultimately failure of the fistula. Does the suturing technique modify the hemodynamics? We know that when creating the AV fistula, the anastomosis can be done either by interrupted sutures or continuous sutures. A study done in 2023 comparing the results of continuous suturing and interrupted suturing technique was done. The immediate patency following continuous anastomosis was 88% and following interrupted anastomosis was 96%. The patency at 1 month was 80% after continuous suturing anastomosis and 92% following interrupted suturing anastomosis. P-value was 0.284 and the patency at 6 months was almost equal between the two techniques of anastomosis, 76% in the continuous suturing technique and 72% in the interrupted suturing technique, and the p-value was 0.097. We need to remember that p-value of less than 0.05 only is significant. Does the angle of the anastomosis between the vein and the artery have something to do to modify the hemodynamics? A study done in 2021 showed the angle at which the vessels are joined plays a crucial role in blood flow dynamics, with a well-angled anastomosis promoting smoother flow and minimizing turbulence. To analyze the effects of different angles, the study was done taking 3 points, one point at the axis of the AV fistula, the second point 1 centimeter upstream in the artery, and the third point 1 centimeter downstream in the vein that has been anastomosed. For example, in this diagram that I have shown, this angle, that is the anastomosis angle, is 80 degrees. Less than 30 degree angles, 30 to 50 degree angles, and more than 50 degree angles were compared. It was noted the proportion of AV fistula maturation after the anastomosis was better in the less than 30 degree angle. So the study concluded that anastomosis angle of less than or equal to 30 degrees was preferable from the AV fistula status point of view, because most AV fistula maturation or least AV fistula failure rates are detected at this range. The final point to be discussed is the non-planarity angle. It simply means how long are we going to take the vein that is going to get anastomosed to the artery. If it is just long enough, it will be in a single plane as it arises from the artery. But if it is very long, it is going to have an S-shaped bend or a C-shaped bend as it comes out from the artery. So, how long should we take the vein? In this schematic representation, there are two planes. The axis of the first plane we have already seen by a point from the center of the AV fistula to 1 centimeter downstream in the vein. Then we mark another point further downstream where there is a deviation from this plane. That is, the vein that has been taken is extra long. This line is also marked. The angle in this representation is 20 degrees. That is the non-planarity angle. Does this angle have any effect on the maturation of the AV fistula? In other words, how does it affect the hemodynamics? Is it good or is it bad? The study that has been indicated showed that there is evidence to show the benefit of reducing re-intervention due to perianastomotic and mid-vein stenosis by a larger non-planarity angle in upper arm fistulas. So, increasing a non-planarity angle by greater than 10 degrees may result in reduced perianastomotic narrowing and re-intervention in upper arm fistulas. There was no mention about the distal radio-cephalic fistulas where a reduced non-planarity angle is always better. So what we have seen in this video is that hemodynamics holds the key to successful AV fistula for vascular access in chronic kidney disease patients who need hemodialysis. We need to take steps to minimize the amount of turbulence and vibration injury following our fistula, hence reducing the amount of intimal hyperplasia, which may ultimately lead to failure of the fistula. This failure can occur at any point of time. It may fail primarily immediately after doing the anastomosis, it may not work, or it may fail after a few weeks, or it may even fail after many years. We can modify the way in which we create the fistula by minding the angle at which the fistula is created, minding the size of anastomosis, and minding the non-planarity of the AV fistula that we are creating. I hope you liked the video. I enjoyed making it. Please do click on the shown link to see more about the AV fistula and a few technical tips to get it correct. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics.